It's come a long way. It's really nice to see some of the long duration products, not the immediate release, not the PRN usage in this population. I think we still have so much more education to accomplish with the PCPs, because the more they know about the nuance of the formulations and the medications, the better they'll be able to use them for their patients. So we're currently working on both the unmet needs. So let's start with the children population. We're working on Vyvanse chewables, and then we're also working on a SHP 465, which is our triple B mixed amphetamine salt product, which is in development. Let's go with the unmet needs in this population. So we know that the formulations, especially in children, or the folks who cannot swallow oral tablets, it's very important that we give them some option. So we know that Vyvanse right now has an option to be opened up. You can really break down the capsules, you can mix it in water, orange juice, yogurt. So we're really lucky to have that in Vyvanse already. But there are some folks who are not able to open up the caplets, and they still are not able to swallow. So we really feel important that the Vyvanse chewable brings that option to them. The second option is to the poster that I spoke about. We're noticing there are quite a few patients in adult ADHD who happen to need longer duration products. So we're working on SHP 465. It's a mixed amphetamine salt, as I mentioned earlier. The ones we've had 15 clinical studies on it. We're currently working on, we just published on the 305 study, which was our child and adolescent study for that molecule, and we're working to finish another last study in adult, and then we'll be submitting that by end of this year. It's the same dose. So it's literally a bioequivalent study to the oral formulation, and making sure that in our resubmission, so we resubmitted that, all we had to do was show the bioequivalence of that medication to the oral formulation. For all medications, it doesn't matter, right? As a physician, you will always have to make sure that we have the right risks and the right benefits. So medications in ADHD, let's start with the non-stimulants, have their own risks and benefits, and with stimulants, especially with Shire carrying the stimulant market, we have the risks of first and foremost being a black box warning. Right? So there's an abuse potential of these medications, but we're very clear that you have the risk and benefit. You have to assess that clearly before we prescribe this medication. Second, yes, there's other risks associated with it in terms of the key adverse events, such as insomnia, decreased appetite. These are very common. There's cardiovasculars, assess their cardiovascular history before you put them on this medication. Absolutely. I think ADHD is well recognized and increased because of the fact that there's education around it. It's the same concept with ASD as well, the autistic spectrum disorder. It's well recognized. The physicians know the comorbid conditions between these two. As long as they know that they're able to treat for ADHD, I think that's the important part. And they add so many other things in addition to pharmacotherapy to ensure that these patients have all the things that they need to scaffold and get managed. So I always call it ADHD management and not ADHD treatment. The goal of medicine is to find a cure. Are we there yet? Probably not in the recent 5 years, but I do hope that by end of my lifetime, or at least I have seen at APA all the research that's being tremendously advanced in brain research, I think will help us to get there. We're just not there yet. The part of the behavioral disorders can be challenging is because you just see the phenotype and you don't always see the brain issues that come with it.